Hello, everyone. We are so pleased you are joining us today. Welcome to the second in our series on AI and global health. Today's session is on navigating imperfect data, challenges and solutions for AI-powered healthcare in low-resource settings. My name is Krista Donaldson. I'm a Bay Area Global Health Alliance board member, honored to be, and I'm also Director of Innovation Impact at the Bio Center for Biodesign at Stanford University. As I mentioned, this is our second in our series on AI, and this one is designed based on feedback that we heard from our first session, and that one was focused on practical insights and real-world applications of AI in global health. And I also want to give a shout out, thank you to Pfizer, who's sponsoring the series, and we couldn't be more thrilled to be working with them to enable these conversations with all of you and these experts. Today, we are talking about the challenges of working with limited data when seeking to leverage AI for global health. And we have several speakers at the leading edge who will share their experiences. For those of you, I'm going to say a little bit about the Alliance. For those of you who are new to the Bay Area Global Health Alliance, welcome. And while we have the Bay Area in our name, we are in fact a global membership organization and central network hub with more than 85 member organizations from across the world. We serve as a neutral convener, a catalyst and connector, brokering multi-sector collaborations and engaging the tech sector alongside traditional global health stakeholders. And more than a third of our members, as you can see here, have a tech focus. We also serve as secretariat for the World Health Organization's Tech Task Force. And our theory of change is based on the assumption that collaboration across multiple sectors, expertise in geography is necessary to solve today's complex global health challenges and advance global health equity. So today, as I mentioned in our last session, we learned about how organizations such as Pendulum were able to successfully use incomplete data sets to build AI models for supply forecasting. And what we heard from many of you is that you wanted to learn more about how different organizations have navigated challenges with data. How might organizations navigate with incomplete data sets? How might you collect better data? How might we best leverage existing or available data? And in the next hour and a half, we will be in conversation first with Rebecca Disler of the Patrick J. McGovern Foundation, and we'll be specifically talking about data, AI, and the global health landscape. And then following Rebecca, we have three leaders in global health AI who will offer examples from their work. We'll have a short panel discussion, a Q&A with all of you, and a special guest, and then we'll wrap up. So before we get started, just some Zoom housekeeping because I can hear some murmuring in the background. So if you could please mute yourself, but please feel free to communicate via chat. And this is a Zoom meeting, not a webinar. So please, use chat freely. We love hearing questions or comments. We'd love you to introduce yourself too as you do that, as you pose your questions for speakers. And we'll be monitoring the chat throughout for questions. We'll answer as many as we can during the Q&A. So I'd like to turn now to our guest who's going to kick us off, Rebecca Disler. And she has spent nearly a decade building partnerships and programs with technology companies, foundations, nonprofits, and governments, basically everyone we have in our membership and many more, to advance innovation in global health. She leads the AI and digital health portfolio at the Patrick J. McGovern Foundation, where she works with organizations around the world committed to advancing health equity through data and AI. She's previously served as Global Health Programs Lead at ID 2020 and Director of Global Health Initiatives at Element, an AI digital identity company. She holds an MPH from the Yale School of Public Health and a BA from Yale University. Rebecca, welcome.
Thank you so much, Krista, and to the Bay Area Global Health Alliance. It is such a pleasure to be here. I also have to say, I love the Zoom format, not this, it's so nice to see both so many new and familiar faces and names. So I'm taking note of this. I love this format. So thank you.
Yeah, I do too, because this allows us to all gather from across the world, and we have so many time zones represented. So thank you. Thank you to the Alliance. Rebecca, let's kick you off. Why don't you tell us a bit about the Patrick J. McGovern Foundation and why it's focused on AI and digital health? And I know we can read online, but maybe tell us give us some framing and then tell us what is not online.
I will. It's always helpful to hear it right from the source, isn't it? So for those who are not familiar with our work, the Patrick J. McGovern Foundation is a philanthropic institution dedicated to advancing AI and data science, public good, and social impact. So health is one of many areas we work across, and we're really focused on how do we ensure that these approaches help us tackle the world's largest societal challenges. So climate, education, journalism. I don't think I have to tell this group that health is, when you look at the state of our public health and healthcare institutions, that is one of our biggest challenges. We've all lived through a pandemic. But I think there's a few things that are unique about our positioning as an institution as we think about this intersection of health and technology that so many folks on the call really sit at. So the first is that we really focus on nonprofit and civil society institutions. So these are organizations that are at the front lines of communities, front lines of this work, who have not always been, though, at the front lines of being able to shape technology and conversations around AI, and really focus on strengthening their capacity and their leadership to really take on a leadership role in that space. The second is that we are very much technology optimists, but we don't believe in silver bullets. If you actually look across our portfolio, and I'll share a little bit more about what this means in health, but if you look across our broad portfolio, you'll see sort of the work that we do around, let's say, applied AI, so particularly nonprofits and civil society institutions that are actually building this technology or leveraging it or using it in their programs. But then you'll also see a lot of investments in what we call the enabling environment and the ecosystem around that. In health, this is manifested in a couple of different ways. It means that we both invest in folks who are at the front lines of building and implementing this technology in health systems with a focus on low and middle income countries, but that we also focus on initiatives around the underlying data and digital infrastructure, on standards and interoperability. But we also look at policy and governance, and then, of course, building cultures of data use and where and how we could support stakeholders from ministries of health down to the health workers and actually using that data to make decisions. And so when you think about us, and I think the work that we do in this space, we just operate a bit different than health funders, right? We don't have a disease focus. We're not sort of organized by disease silos, if you will, but we really think about where are the opportunities for AI and data to strengthen health systems, particularly integrated primary health care, where we can be catalytic, and then how do we be good funders of digital health through that lens.
I think you heard a collective like amen when you said that you're not you don't see technology as a silver bullet, because it's so important to take this holistic approach like you're talking about with the environment and thinking about needs and thinking about all levels of people. So that's really fantastic to hear. I would love for you to talk to, I mean, I know we don't have a lot of time, so I would love for you to talk to you about like what are some of the key findings or learnings that you're having from your work and from your support of different organizations like this.
So absolutely, and I'll frame it in the context of our conversation today, which is data. And I think something that's been, I'll just to give you sort of like the big picture framing, because it's something that always stops me in my tracks, right? Which is 30% of the world's data by volume is generated by the healthcare industry. There's actually a tremendous amount of data out there, and we see partners who are working with tremendous amounts of data. The challenges are in the types of data, right? As you say, it's incomplete, it's poor quality,
There's maybe too much, right? That's the other thing.
Too much, right? And too much of the wrong data, right? I think one of the really early findings that when we really, even when we were just setting up our strategy, I think something that became really clear to us was how much in the digital health ecosystem has really been designed for data collection and for use of data by someone else, not necessarily the person who was collecting it. And I'll plug, I don't know if she's on the call, she might be, I can't see everyone here, but Tracy Lee at D-Tree, another phenomenal partner of ours, like truly published a blog post yesterday around AI. I'll put it in the chat. AI doesn't say
please do.
People do. And she talks about this in the blog post. She actually captured so many of the lessons that I think we've seen. So one, you have these digital health systems that are designed for data collection, right? So not necessarily data use. Health workers need to be able to use that data to make decisions, not necessarily to collect it for someone else to, it's helpful to inform a programmatic or policy decision, but it messes up the incentives, right? You want them to be able to use that data to make a differentiated care decision, for example. So I think that's one thing that we've seen across the spectrum. I think the other, I'll just name from a funding perspective, is that so often we've funded digital technology as part of projects.
7 to 11 inclusive.
So we have larger projects that we may fund across the whole spectrum, and then folks are kind of siphoning off funds to try to build digital products on top of that. And I think that's something where we've tried to flip that model, where we say, actually, once we identify what is that what is the product need there? How do you invest in the product roadmap and provide a bit more of that flexible capital to say, build a resilient digital health product, not something that's going to work for this project, but that's going to be a product that's going to solve a market challenge at scale. And so it's been a bit of a different approach. I think the other piece, and this goes back to what I was sharing about that data decision challenge, or the data for decision making, was even with our partners, and I think we'll see some great examples of this from the folks on the call today. But even if we can train AI models and really good AI models, it still leaves this question of what are we doing with them, right? I think about risk stratification all the time, and we'll see some good examples of this, right? But it's so important to say it's not just the model that can really predict, like it can be a really good predictor of risk. It's who is taking that output and making a decision with it, right? What's the referral pathway? Is there even a place to refer, let's say, a woman who's been termed high risk? Is there a place to even refer her into? And so I think when we think about and again, sort of that, bringing it back to sort of the lessons learned and the questions around data in this conversation today, it's how do we identify and work with partners who can both bring the perspective on data and what and how we can, what are the things we can do with data to train these models, but then who are thinking very much about, and how are they being implemented in health systems, and really sitting at that intersection of, we can be really smart about the data, but we need to be really smart about the implementation as well, if we're going to see any impact from these tools.
Rebecca, when the foundation works with different groups, like you talk about how like changing the model of how data is collected and how it's used, and even really, I think what I'm hearing is like a shift in mindset around, and I love it, I'll just say from a design perspective, because, you know, as designers, we want people to be thinking very early on, not like kind of tacking data on after the fact. And so a question for you is, when you engage with different organizations, like, do they come to you with ideas and you work together to help shape it, or are they fully baked? Or like, can you talk a little bit more about how you're doing that with different organizations?
Yeah, and for the folks that have worked with us, I hope I hope this rings true.
They can chime in later.
Well, let them come in and correct me. I think it's a bit more of an art rather than a science, right? I think that there are certain times where we have folks who come to us and they say, we have a vision for what an AI-enabled continuum of care could look like. And we have a really strong set of government relationships. We've got a really strong technical team. And what we're looking for is kind of that catalytic funding and to sort of launch this particular initiative, right? And so there are folks who I think do come to us with some of these ideas fully baked, if you will. There are other folks where some of the work itself has been much more of a conversation, right? And I think oftentimes what happens, if I will, to be transparent, is I do think sometimes folks approach us like a public health foundation, right? They come to us seeking funding to implement health programs, which is not really our positioning in this space, right? As I shared at the beginning, we're an AI and data science institution. And so it just means that we get to approach it with a bit of a different perspective, right? So they may come to us saying, here's the health program that we're seeking to implement. And we can actually sort of say, well, wait a second, you've got, as part of that program, tell us a little bit about the digital architecture that you are looking to leverage as you build this out. And that tends to unlock a very different set of conversation, where it turns out they may be able to pull in funding from, let's say, a USAID or a Gates Foundation or some of our other funders we work quite closely with in the space. And then we can come in and say, where and how are you leveraging data, digital, and AI? And how can we be catalytic in supporting you in leveraging that, recognizing that that's not always part of like a larger health program. So it really does run the spectrum. Like I said, it's a bit more of an art rather than a science. But I think one of the things that we, across the institution, whether it's health, whether it's education, whether it's journalism, I think something that we pride ourselves in is asking good questions, right? So we often say that our partners, we practice trust-based philanthropy. Our partners are the ones who are the experts on this. You're going to hear from some of the experts directly that we've been working with. And so for us, it's how do we ask smart questions to help figure out how to best strategically use our capital to drive forward the outcomes that they're seeking, and be able to do it in a way that says, let's step outside the box and maybe the traditional boundaries of how we think about a relationship between philanthropy and a frontline organization.
That makes a lot of sense. And I think, I'm putting myself in the shoes of like maybe some of the smaller organizations too, who might be on the call today. And they might have a vision of how to use AI or digital health. And maybe I'm also speaking about myself in some level too. But, I don't fully understand the whole, like what the capabilities are. And what suggestions do you have for organizations who may have a vision, but they know, they could build out like just how they could build out more, or they could, envision more or do things differently? Like what are kind of like, how should they be thinking about it? How should they be getting feedback on those visions?
So I think in many
And
ways,
not to overwhelm you with a bunch of questions
oh,
after
well, I love this.
from
I love this.
everyone, but yeah.
And so I will say in some ways it's hard to give that answer, right, in an aggregate,
Yeah.
right? Because each institution is at a different stage of their data maturity. And we at the foundation actually do a lot. There's a whole other sort of set of activities that we do on working directly with nonprofit and civil society institutions beyond health that are thinking about like where and how do we meet you at different points of your data maturity, and support the work that you're doing. And so we can, that's longer conversation around that, but happy to dive in. I think some of the, in many ways, it's conversations like this, right? It's opportunities to come together and learn from folks who are doing it. And I think, again, one of the things that funders can play a role in, these communities can play, the Bay Area Alliance can play a role in the Global Digital Health Forum. There are communities of implementers, right? Folks who are building and implementing, who have worked with ministries of health for decades, who have worked on digital platforms for decades, who have seen the evolution, who have seen what works and what doesn't. And I think one of the things, again, that I think is a responsibility of folks like us who sit at the philanthropies and at the funding level, is to be able to connect folks. It's one of my favorite things to do when I sit down and I chat with a new organization, even if they're not sort of a fit for our strategic hypotheses, to be like, okay, you're asking really good questions about, let's say, how do I think about developing like a point of care? I'm thinking about it, some sort of like data-driven kind of point of care tool, right? And we can say, well, one of the things you're going to want to think about are these questions of standards and interoperability. Here's a set of folks who, for example, are experts at adopting FHIR, right? The healthcare interoperability standard, right? Have a conversation with them and get a sense of whether that architecture is the one that you should be pursuing. We have some folks who are saying, we don't have any of that AI data science talent at our institution, but we have a lot of data and we don't know what to do. So it's like, how can we then connect you with, let's say, some of these smaller AI labs that we know, or, and you'll hear again from different folks who have different models, right? Some people, and actually, I'll put out a call to action for our speakers, because I think we actually have a range of solutions on the call in which some folks have brought that talent in-house and some folks have partnered externally in order to leverage that. And I think we've seen successes in both, right? And that's where it's that art versus science, right? And again, we'll turn to the experts on this call, right? But there may be moments where it is important to bring that expertise in-house. And there are moments that say, actually, we have the expertise in health that we need around health systems, where and how, like, who are the folks that we should be partnering with around the AI talent, and how do we bring that AI talent closer to the challenges, whether it's within our institution or whether it's through strategic partnerships.
That's great. Yeah, no, and we'll return to that. Maybe we can ask the panelists that as part of the Q&A to share their experiences. One of the things you've already kind of talked about this, but I would love you to say a little bit more too with the Patrick J. McGovern Foundation. It is AI and digital health driven. And there is this balance with needs-driven work that many of our members do. And I would love for you to talk a little bit about that. You did talk a little bit about supporting all the way through and supporting the ecosystem, but how do you at the foundation balance supporting, meeting the needs while also leveraging a specific type of technology or technological approach?
So one of my favorite questions to ask, and I should say I've worked at this intersection of AI and global health since 2017. And one of my favorite questions to ask from the beginning of time has been, is this really an AI problem? Right? And being able to like just ground, like there are so many folks that are, I think, excited about these solutions, are excited about these approaches. And I think particularly with the rise of LLMs, which is really the large language models that have really democratized both access and use around AI, right? And an ability to for lack of a better word, to play around with it. But I think one of the, like, particularly when we're looking at the applied AI, being able to start from a perspective of, is AI really needed to solve this challenge? And even just asking that question up front, like, you really start to dig into it. And what it starts to unlock, to me, like, I'll just name, I think some of the most exciting use cases are some of like the behind the scenes work. And again, I think you'll hear some of examples of it on the call today, right? Where there's a lot of focus right now on the kind of sort of a direct link between implementing AI and health outcomes, right? But there's a whole, and again, Tracy actually, I think, mentioned this in our blog post. Once I'm done talking, I will add the link. There's a whole host of approaches that really look at the application of AI and data in health systems, right? Or that are a little bit more behind the scenes, where like, how do we make this work more efficient or more accurate, right? And I think those are the sets, when we think about like needs, right? I think we so often think about the community and patient needs, and I think that's exactly where it needs to start. But we're also thinking about like, what are the health system needs, right? And what are the things that, maybe this could help us do differently in the health systems that'll help us better serve those communities. The last thing I'll say on this is, I think everyone loves to talk about human-centered design. And I think it becomes very clear when you start, there are folks out there who say we take a HCD approach. And I appreciate that, but I think a lot of folks out there say that they do that. And it becomes very obvious when you start to work with partners who live it, right? Where it's not the sticker that they slap on their approaches. It's the, before we even thought about implementing AI, we actually went out and asked our community. I'll give you just one quick example. We had a partner that was doing some really interesting work on using AI to kind of assign different interventions to increase uptake of immunization. And before they even began to have a conversation about how you might use AI in that context, the first thing they did was go out to their communities and say, are there any of these interventions would actually encourage you to take your children for immunization? And they started there. And it was a simple conversation that had nothing to do with data or AI. But from there, we're actually able to build a really meaningful and impactful solution.
That's very cool. And I actually, do you want to put a plug in? I really appreciate that you brought up the kind of behind the scenes type of work that AI can do, because I believe, and Lisa or Sarah can add a link, but we talked about that actually at our annual meeting last year. The Bay Area Global Health Alliance talked about several examples of non-traditional uses or examples that we wouldn't have necessarily thought of. So thank you for bringing that up too, because I think that is something that we don't talk about. Okay, I'm going to give you a little bit of a rapid fire last question, which is, where do you see, I mean, we are living in this time where we hear so much about AI, we're seeing things change very, very quickly. I would love to know where you think healthcare is going to be in the next 2 years, where we're going to be in the next 10 years.
Yeah. So let me take a little bit of a provocative answer on this, which is
all the better.
I do fundamentally believe that AI has the potential to rapidly transform healthcare. And I think we are seeing some incredibly exciting use cases. Obviously, I think there's a easy answer here around large language models and how that's going to change the relationship between patients and clinicians, how that's going to accelerate clinical decision support, or even change really the nature of relationships. But I think something that I come back to is that at the end of the day, there are still some fundamentals around data and digital systems that no matter what those innovations look like, you still need in place in order to accelerate them. I come back to the risk stratification example, right? Even if we can say this person is at risk, right? Even if you have the LLM that spits out the response that says this person is at high risk, here's all the things you need to do. If you don't have the ability, the authority, or the knowledge to take all of those steps, that's still not going to lead to the health outcome. And so it's all to say that I do think there are, and this goes back to, I think, some of those behind the scenes use cases. I'll name one of the things that I think we all need to keep an eye on is some of the riskier AI use cases, right? The ones that are really that kind of at the forefront of that patient-client interaction are being explored in some of the riskier environments, in environments where we don't necessarily have the policy, the data governance, or the privacy kind of regulations in place. And some of the less risky ones that we're thinking about, note summarization, kind of back-end office work is being done in environments that actually have a lot of regulatory that have a more mature regulatory ecosystem. And I think that's a balance that we really need to be mindful of, because one of the things that we're doing is saying there are so many areas where there's just so much need, and there's so many challenges on capacity. And so we see a lot of potential in that space. And I think we all want to get there, but we have to be really mindful about how we do that, and to make sure that we're investing in some of the other components that are going to let us say, as we invest in these AI innovations, here's how it's actually going to lead to meaningful change in health outcomes. So that's my more provocative.
Yeah, so a lot of potential, but also with mindful warning, it sounds like. Thank you so much, Rebecca. So a clap for you. And then we are now, everybody, we are going to turn to 3 of our featured case studies. All are going to be focused on working with limited data. And it's exciting because we're looking at it from 3 different levels. We have Yasmin Chandani, the CEO of In Supply Health, who's going to kick us off. She's talking around the systems level. We have Lucien DeVoe, and he is from Palindrome Data, and he's going to be more focused on the provider level. And then wrapping us up, we are going to have Sathi Rajashekharan, and he is the co-executive director of Jacaranda Health, and he's going to be speaking more at the individual level, so the patient mother level in his case. So I would love for Yasmin to please kick us off, and welcome.
Thank you so much. And good morning, good afternoon, good evening, depending on where you're coming from. And I'm really delighted to be here today to share our experience working with how we've enhanced forecasting for supply chains in public health supply chains in Kenya and Tanzania using AI. And InSupply is an East African health advisory firm. We're in our startup years, and our mission is to transform lives by co-creating innovative and sustainable solutions for health. And we do this with the communities we serve. And just a quick note, I, of course, have done this work with this is part of the team on this slide. Front and center is Ken, who leads the project. And there's 2 ladies of us on this team. So next slide. I just want to acknowledge that we do this work with a lot of really important stakeholders. We've worked in partnership with the governments of Kenya and Tanzania from the start, both at the national level, and Kenya is very devolved, so also with 4 county governments. We also partner with Afya Intelligence, and sort of to the point that was made earlier, in Kenya, we have the AI capacity in-house. We brought it in-house. And in Tanzania, we partner with Afya Intelligence who are our AI partner there. We work with JSI, who we're affiliated with on the forecasting methods. And then, of course, a big thanks to Rebecca and the team for funding this. So next slide. And I wanted to start with a little bit of background for those of you that may not know supply chains well, to sort of explain why forecasting is important. And so credible forecasts help stakeholders at all levels of supply chains to promote adequate, affordable, timely supplies. And that's the goal, so that when people go into health centers, they can get the medicines they need. And forecasts are never 100% accurate. We've been supporting forecasts for years with imperfect data. We always approach forecasting from the perspective of that it's an art and a science. And the art piece is really tapping into the collective experience and expertise of people in the room, because the data has been so imperfect. And you can see examples of what our data looks like on the side, but really, enhancing forecasting alone is not going to solve stockouts and expiries, which are the things that supply chains try and address. But because forecasting is not an endpoint or an independent step, it's one step within the ongoing supply chain management system. But for us, it's a critical starting point for visibility and transparency. And so our endpoint in starting this work with AI was to achieve more robust forecasts, which means using multiple data and multiple methods. But we recognize that the root cause, the barrier to those more robust methods, was to reduce the burden of data processing and management, which was heavily manual. Next slide. And as I mentioned, we've worked with imperfect data, throughout the supply chain. And generally, we use a framework that whenever we're looking at system improvement, we look at people, process, data, and technology together. And we always consider a few principles. The first is that using imperfect data is better than no data. And we've done it even without AI. Data quality improves when data is used routinely. And I think to the point of human-centeredness, in our experience, the technology is best adopted and scaled and sustained when it really solves a problem that's defined in users in a way that works for them, which means they're sort of part of the process with us. So in our approach, we started actually by acknowledging that AI can be scary. In fact, for me, it was sort of scary before I started working on it. And so we started with unpacking it for our stakeholders, breaking it down, training them on the concept before we even started the process. We used a very transparent process, and our ministry partners were the ones who set the pace, which might slow it down a little bit, but in the end, it means that they now feel ownership of the solutions, and more importantly, they understand them. And we also built human in the loop touch points so that they felt in control of the data at all time and had confidence in it. If we go to the next slide, please. So we started actually not with AI, but we started by addressing the biggest pain point, essentially in automating data extraction and cleaning. And we built the sort of trust and excitement for AI from there. So, you know, automation is not AI, but we literally removed a significant barrier that prevented users from ever getting excited about using their data. And they weren't not excited about the data because it was imperfect. They were just not excited about data previously because of how unwieldy it was using manual systems to take it out, to clean it, and all the rest of it. So I'll share two examples. One is from Kenya, where we worked with the family planning program, and one is in Tanzania, where we worked with the National Quantification Team for Essential Medicines. And in Kenya, we managed to reduce processing time from 2.5 days to 15 minutes. And in Tanzania, where they have to approve forecasts at each facility level, it basically was reduced from 3 weeks to a single day. And because of that facility of extracting data, we could now extract much more than 12 months of data. We could triple the amount of data and disaggregate the level of data. So this leads us to the next slide, where we can talk about sort of how we now introduced AI. So because we had that baseline of trust, we could now introduce much more robust forecasting methods by using models and machine learning algorithms that could really look at the data in a different way. Remember, now we have a lot more data. It's still very imperfect, but the data was extracted for 3 years. It was clean. So the basic issues were solved in terms of the data. And then what we could do in Kenya, they only used to use 12 months of data, and they used a very simple method for forecasting. We used these algorithms to analyze data and select the model with the best accuracy for family planning programs. In Tanzania, we actually explored 4 models. And in Tanzania, each facility has anywhere from 100 to 1,000 products. They need to review manually and clean and approve. And so we tested those every line against all 4 models and selected the best model. And practically what this means for people, for example, family planning, contraceptive is not a seasonal product. Use does not depend on seasonality. Antibiotics, antimalarials, those things are affected by seasons. In the past, pre-AI, we had one size fit all in terms of methodology to use. Now we could actually adjust the robustness of the forecast based on the AI looking at what was specific to that particular product. If we go to the next slide. And so I think the other thing I wanted to say is that, and this comes to the issue of data use and the way we approach it. For us, the technology alone can never really, people are scared of the technology. And so one of the ways in which we built that confidence and trust was really building in user-friendly visuals at all stages that allowed users to interpret what was happening. So you can see on this slide, right? This is the data before it was cleaned, the data after it was cleaned. And we did this a lot throughout the tools so people could understand what the difference was, ask questions, and they have control over approving the clean use of the clean data for the forecast. Next slide. So I just wanted to end with some of our key lessons. for us, any technology, but especially something as new as AI, the early and continuous stakeholder engagement is really critical, and co-creating some of those solutions is really important for building the trust, ownership, and sustainability. And I think it gets back to what Rebecca was saying. If you want someone to use this tool after the project's ended, this was really critical for us. The next thing is that building those visuals and making the tool user interface really interactive, so that the users could engage with the solution, they could perceive its value. That built their confidence. And the more they used it, the more they got excited about the different use cases that they could use it for. And then that led to them seeing data as a lot more valuable than they ever did before, which was really cool. But it also meant that they suddenly became worried about data security, which has never come up in any of our forecasting discussions before. And they were like, oh, you mean people can access this data in 15 minutes? Because previously, why would anyone spend 2 days trying to download that data? Now suddenly the data has value. So I think just thinking ahead and anticipating some of those concerns would be important. And then just the final note is that AI does add value to imperfect data. But it really depends on if the people and the process aspect of any technology, but I think in our experience, AI is done right. People get really enthusiastic and their excitement grows as they realize how much easier their work is, how much more effective they can be with their time. So I think we started with a group of stakeholders that was really scared and cautious, even very conservative against it. And now I think it's been a sea change in terms of that audience. Thank you very much.
Thank you, Yasmin. We were going to ask some questions, but what I think I'd like to do is please keep the questions coming in the chat, but we will turn now. So anyway, we will do questions at the end of all three speakers. And Yasmin, some really great themes that I know we will be returning to. Thank you. And then I am going to invite Lucien Deveau, the co-founder of Palindrome, to go ahead. Welcome, Lucien.
Good day, everybody. Thank you for having me. I really appreciate the opportunity to just share some of our thoughts. And, one of the first things that I was kind of entertained by was just the title of our session, which is Navigating Imperfect Data, which sort of implies that there's perfect data. And I've spent the vast majority of my career in the private sector, actually, at small tech startups to big investment banks, and actually most recently at a US company, one of the biggest big data companies in the world. And I'm yet to find this perfect data that we might be alluding to. So I really just want us all to maybe breathe a sigh of relief that whatever we describe as the data in the public health sector, it's actually, quite compatible to what I've seen in the private health sector. So it's not about navigating imperfect data, it's navigating data and the general kind of nuances that come with that. So that being said, I will say we have a very high functioning team in South Africa. I'm coming to you from Cape Town today, and all of our folks are here. And we are sort of a local team driven by this collective mission to bring custom AI solutions to our communities. And we work through a number of African countries. So let's talk a little bit about the types of data maybe we see out in the field. Typically, you have two kinds. The first being this routinely collected surveillance data, maybe operational data. And then the second type, a lot of maybe academics or universities have done these research studies, and they just have different flavors. And so what this routinely collected data is really good at is sort of the reporting to PEPFAR mostly. I think Rebecca alluded to, like, all this data collection is actually ending up benefiting funders as well as sort of maybe folks in the program headquarters, in their ivory towers, thinking about how they should do things at the facility level, which doesn't necessarily get to the patient and decisioning sort of benefit. And then the other kind of data we see quite a lot of is, again, this research studies, very rich kind of longitudinal data sets with, you know, hundreds of columns, let's say, and descriptors. But again, we're actually able to find a lot of profiles that come out of that. But once the study's over, it's kind of hard to actually operationalize those insights. And what we are seeing is that, you know, while we love academics, those things take years, and, you know, you have a randomized control trial. And by the time the policy sort of gets out, the world's changed, and things have, you know, been different. And we see that actually in our daily work. And I'll speak to a little bit about that as well. But let me hone in on what we think could be driving some of these data challenges. And so the first thing we've seen, we are by birth a data science company. That's how we started. We quickly evolved to realize that great data science is not enough. We can build these amazing predictive models, but if we don't have a mechanism to distribute that information, most of the partners sort of aren't able to consume a predictive algorithm. And then the second thing we saw quite acutely is that even when we build tools, operationalizing those tools in the field is like 80% of the problem. You know, the easy bit turns out that actually building these models and overcoming a lot of those data challenges is, you know, actually the easy part. But with regards to the data challenges, one of the things we see is this lag between when the patient is coming in for a consultation and when that data gets digitized. So very often, most of the public health sector, certainly in Africa, is still all file-based, paper-based, and it takes days, if not weeks, to kind of data capture that information. So you're already out by a cycle when you're trying to make a decision with a patient. So one of the work we've actually been doing with the McGovern Foundation is kind of getting these digital tools in real time at the point of care so that those data can be captured at a consultation, and we can kind of make decisions in real time at that point. And our predictive algorithms can actually benefit the patient immediately. And the reason why this is so important is because what we call interruption in treatment, or was previously lost to follow-up, is if you are trying to prevent someone disengaging from care, it is a lot easier to do that while they're sitting in front of you. If you are figuring out retrospectively that that patient's not coming back, it is a nightmare to trace and track. It's very expensive to actually bring them back into care. So what this allows us to do is to kind of support them better. So triage and segment by risk while they're sitting with you. Do you know if they're at risk for missing their next appointment or disengaging from care while they're still with you? And we believe that that's sort of a bit of a game changer in terms of the type of care and the ability to do differentiated models of care while you still have your patient in facility. The next thing that is absolutely critical is this data privacy idea. And again, as I mentioned, I've worked for many, many years in the US, and the maturity of the data ecosystem is quite well understood. People know the rules of the games. You work with a bureau or a FICO to get to a credit score, and it's quite a fluid system. There's a lot of efficiency there. Even in South Africa, we've got this really great legislation on data privacy, often based off things like GDPR, and they are a necessary mechanism. But because it's so new to a lot of folks, we are struggling to just help people to understand. So there's quite a lot of education around, you can do this, but you can't do that. And very often the sort of the confused mind just says no. So there's a lot of like no's coming out about just the lack of understanding about what is actually possible through good data sharing and exchange. And so the speed of accessing data kind of really slows things down quite a lot on these projects. You know, we have like a 6-month project or let's say a year project, and it takes 4 to 5 months to get hold of the first load of data because the bureaucracies and the paperwork is kind of tying up quite a lot of the innovation. I think I've kind of touched on this regulatory framework and the maturity of the regulatory framework being quite tricky. And then again, the reality is there are lots and lots of different systems being introduced by different stakeholders, by different funders, by different organizations, whether it's the Department of Health or a PEPFAR-funded kind of implementing partner, and it's very fragmented, and it's kind of hard to pull all these things together. Because what you really want, especially when you leveraging things like machine learning, is the ability to have a single view of the patient. I think Rebecca mentioned not being in the silos of, oh, I'm just looking at their HIV treatment, but actually taking a much more holistic view of the patient, and pulling all those different systems and data sources together can be quite tricky. A little bit more on the practical side, what we've seen again is building those machine learning models, building the tools is 20% of the job. It's only about how do you get those tools and operationalizing them in the field. So one little bit of a painful thing that we've kind of had to accept is that if the data is inconsistent, the end users will start losing trust in whether it's the system. I think Yasmin made a great point about surfacing up these very good benefits and finding value in the data, and that's how they gain the user adoption. This is sort of the opposite, where the data is now disabling trust and adoption in the system. And then one of the best ways we've seen to overcome and navigate this imperfect data are the people. The one thing we see time and time again in these high-performing facilities that are using data well versus facilities who are struggling, it is that it is the people. And we just had a very sobering experience where one of our more recent hires came back from a clinic and almost in the most cynical way said, I don't think any of what we do matters, because it only comes down to what the people in the field are doing. And I think there's truth to that. But I think there's a balanced approach where if you have good people and bad data, that's not great. If you have great data and bad people, that's not great. But if you can have great tools and great people, you really are able to kind of have real impact. And then just to wrap up, I think we are seeing this overwhelming number of tools from different stakeholders, and that is creating a high burden for the healthcare workers. And so a big part of our job is to kind of find ways to be technology agnostic or tool agnostic, and really to find a way to embed all of the AI in their existing tools instead of, adding new tools, which again, we've actually managed to do quite a bit of. And then my last point, I promise, is what do we do now that we know that Lucian is high risk, and that changes over time. Sometimes I'm doing well, sometimes I'm struggling. So the timeliness of the predictions obviously important, but the intervention that we match that patient with is actually the most important thing. And when I talk about the biggest struggle in the sector, it's actually closing the loop that Lucien Deveau on this day was high risk. He got these interventions, and those were the outcomes. Once we can feed that cycle, we sort of have this, what we're calling a flywheel, where we're now able to learn about the predictions, learn about the matching of the intervention, and then really able to improve and iterate now that we have this full cycle and have closed the data loop. So I'll stop there. And again, thank you for your time and allowing me to share some of my thoughts.
Thank you, Lucian. Yes, that was fantastic. And I'm already seeing some themes emerge with you and some of our previous speakers. So thank you. We will turn now to our last spotlight case study, which is Safi Rajashekharan, and welcome, Co-Executive Director of Jacaranda Health.
Great, thanks a lot. So I'm gonna tell you a little story about how we've used data and then improve the data that we have and used AI. So I work at Jacaranda Health. Our mission is to improve the quality of care for mothers and babies to reduce maternal and neonatal mortality. We do that by getting the mom to care at the right time and the right place. And we do that by improving the care she receives once she gets to the facility from providers, primarily midwives. And then we wrap that together by leveraging the data that we get from some of the programs that we deploy to then improve the health system as a whole, just echoing some of the comments that Rebecca made. Next slide, please. When we talk about getting the mom to care at the right time and the right place, we use a digital health tool. It's called Prompts. When it comes to the mom, Prompts is just text messaging back and forth for the mother. She signs up at the facility or through a community health worker. She's getting information about her pregnancy or her newborn. She's getting maternal health information, but she also gets information about when to go back for her appointment, a bit of coaching around her appointment. Here's what you should ask for. She has the ability to text in and ask questions to a help desk. And we use AI to triage questions that are coming in. We have, over 120,000 active users per month. At this point, we're getting 6,000 questions a day. There's no way we could be answering all those questions within minutes without using a form of AI to triage the questions, identify the most urgent, and then have a human in the loop to be able to answer the questions and adjust the responses. And then finally, we actually get feedback from the clients to talk about what their experience was like and aggregate that information and then share it back to the facility. So when it comes to AI, we've walked a journey for a number of years now, using a number of different machine learning tools, such as natural language processing, and then blending that with large language models more recently. I'm really not going to talk about any of that for the majority of the next couple of minutes. Next slide, please. But I'm going to talk about how to solve a problem which has minimal data. And the problem we have here is many groups, many researchers, many ministries, governments, hospitals, all want to understand, what's happening at the facilities. What's the client experience at facilities? Are they happy? This is often called a customer satisfaction survey in some of the counties we work with. But whether it's a customer satisfaction survey or a respectful maternity care survey, most of what's out there that's validated and well studied, and there are a number of really great studies that look at this question, are not really practical to implement in the field and at scale. I mean, these are 10 to 15 questions. Moms just don't have time for this. Who's going to administer the survey? It becomes expensive if you're doing this paper-based. And it's not anonymous. So if you ask a mom when she's leaving a facility, you're highly likely not to get the answer from her because she feels that she may not be safe, especially if she's had a negative experience. Next slide, please. So we took this problem, how do you get effective feedback about the care that the mom experienced? And we said, well, can we just ask one question? And the first time we did this years ago, the question was, what was your quality of care like? And the answer we got, almost 90% of the answers were poa, which in Swahili means, yeah, it was fine. And so we changed the question and we said, okay, were you treated with respect? And we kind of defined a little bit what we meant by respect. And you can see that in this text message here, no physical abuse, treated with dignity, privacy respected. And the answer to were you treated with respect, especially if it was a no, was sort of opened up a story from the mother who just explained her situation. And we realized, oh, it's one text message or one and a follow-up, so 2 text messages that really allowed us to get all of this information. And we were able to do this at the sort of 0 to 1,000 user level, right? Like very small at the time, but we were still getting data about that mom's experience. Next slide, please. So we would take this data and we would share it. So, when at the 0 to 1,000 level, it was, 80% of your clients are saying they were not treated with respect. And then we would kind of manually try and figure out what they were saying and try and draw some insights. most of the facilities actually wanted to see all the comments, and it's still the case, just really hard to parse through. And then we started categorizing it. And, in this particular case study from Makueni County in Kenya, we realized that, long waiting times were an issue. We shared that information back with the facility, and the facility took action based on this. They were really struck by the fact that most moms were saying that they were waiting for a long time. So they put in more rotations on the busy days, which are typically market days, and hired more staff, which they were lucky enough to be able to do. And we saw wait times decrease in this particular facility, which is fantastic. This is what you want. You want to use data. You want to collect the data in a simple way. You want to share the information back, and you want action to actually happen with that information. Next slide, please. Okay, so now we're getting to, at a point we were getting to 100,000 users, and we realized we were getting information not just about respectful care, but about whether the mom received blood pressure readings or got her nutritional supplements. And we started aggregating this data and creating dashboards for our Ministry of Health partners. And this beautiful dashboard was great for us. We love it, but we had to adjust it quite a bit for our ministry partners, because just because we like the data doesn't mean everyone understands when they see data gridded in a certain way. They may not be wanting to see specific indicators. So we did a lot of design work with the ministries to try, or the staff at the ministries, to try and understand how they actually want to see this information. And we've got sort of a version 3 coming up now that I think that has received a lot of positive feedback, which is exciting. Okay, so all of this, no AI. We are at a point where we've been able to do these kind of aggregations, et cetera, and didn't need to use AI for anything. But next slide, please. But we do use AI, right? So we have been using natural language processing to answer questions from mothers, particularly in an instance, let's say a mom says, I'm bleeding. We're able to detect that, say, this is about bleeding, answer the question. This is about nutrition. We don't need to answer it immediately. We can answer it later on. But coming back to that respectful care question, when someone starts to tell you a story through text message, that's a lot of complicated information, right? That's not just one thing they're talking about. That's many things. And now we're at this 100,000 to 1 million users level, or 1 million plus users level, and we have well-curated data. We're able to classify it. Now you can start training a model to say, okay, can we actually identify the subject that this mother is talking about, or the primary subject, and summarize it so that we can share those scorecards in a more automated fashion. So we had to walk this journey to get to this point for the respectful care piece, because it is such complex information. But that doesn't mean we weren't able to achieve results with the earlier data. And I will say this isn't perfect. We've got a really good model that can detect the primary topic of conversation that the mom was talking about with respect to respectful care. But if you have multiple issues coming through, it's still not that great. And we're working on that using things like large language models blended with other tools to be able to really get at the statements that the mothers are making. And so that's it. So the main message is, from me at least, is figure out what problem you're trying to solve. You absolutely don't need AI at the very beginning, but you can start building the data set you need that can eventually be useful for AI-based tools. Thank you.
Thank you, Safi. Fantastic. I want to ask, I'm going to invite all our panelists, including Rebecca, if she wants to join. We're going to have a few questions for all of you, and maybe even some discussion amongst the two of you. And then I'm going to open it up for Q&A from our audience. And thank you all for who've been putting questions in the chat so far. And we will get to that in about 10 minutes. But a question for all of our panelists too. And I appreciate that you spoke both to the challenges and to some of the insights you've had, which is really what I was hoping we would talk about here as well. But I'd love to hear, you're all doing this successfully. I would love to hear, what challenges, as you were on this journey to leveraging AI, to looking at your data sets, I assume those challenges changed over time. And Safi, you spoke to this a little bit with, when you only had less than 1,000, then 10,000 and onward. But maybe each of you could speak what was the biggest challenge when you were starting out, and what's some of the bigger challenges you're dealing with now as a more mature organization? And you could speak to like what's your priorities around that. So why don't we just go in order? Yasmin, if maybe I could turn to you quick first, is that okay? Not to put you on the spot.
No, it's okay. I think I sort of alluded to some of it. At the beginning, we were doing a very hard sell for AI
Yeah.
because there was a lot of fear about it. And so our biggest challenge then was like making sure we really walked very slowly with our partners. And we were working at sort of 5 different clients in Kenya and 1 in Tanzania. So that was the first one. I think we turned the corner. It's what Safi said at the end, right? It's once we didn't start with AI. We started with the automation of extraction. We stopped using the word AI for a point and just talked about advanced analytics and automation and just gathered the data. And once they could see their lives becoming so much easier, because instead of spending 2.5 days, they could do it in a few minutes, they were much more trusting. And so then they started to ask, I think because that speed resonated so much with them, they wanted everything else to move at high speed as well. And once we did start using AI and the machine learning, they were like, but let's do this and let's do this. So now we have a backlog of requests. Can we do this for supply planning? Can we do this for resource allocation? And we've got it at different levels. So I think, and can we include this data and that data and this data? And I think we can't work that fast. So, and also there's process to do in the background. So I think that's been the progression of ours. There's so much excitement and confidence in the approach now, but I think we're not able to keep up always. And it shouldn't move at high speed. Like Safi said, I think there should be a process that you go through.
Yasmin, what I love about what you said too is that it's almost like going back to Rebecca's comments around people having a vision. It's like once people can see the power of it and they build the confidence, they're imagining and have these visions of all these other ways that they can leverage it. Just really quickly before we turn to our next panelist, are there any barriers that you're seeing now as a more mature organization using it?
I think because the demand is so high, I mean, the data is, I think someone said this at the beginning, it may have been you. Not all the data comes in the same way. So in Kenya, we're working with MNCH, Maternal Child Health Program, Family Planning Program, and 4 counties. And the 4 counties have like thousands of products and their data is really difficult. So I think I would say it's managing that expectation that it's not a silver bullet for ourselves. I'm not sure if I understood your question, but if you're asking about we as an organization, I think we have to be careful that we don't get sucked into the vortex of only doing this and not focusing on the whole people process and thinking long term, connecting the tools and making sure it's systematic and connected with the system.
Great, thank you. Lucian, can we go to you?
Yeah, sure. We've been doing this since 2017, so it feels like a long time, especially in like this AI world. And we can sometimes forget today, like, yeah, obviously we have to use AI and it's everywhere. Like every single like chat app or tool is pushing the AI. But I remember back in 2017, sitting in DC talking to like the head of PEPFAR or something, and they're like, absolutely not. This is crazy time. We cannot do this. Cambridge Analytica came after that. And there was just a lot of like, negative connotations about these are healthcare patient data. So I think we had to kind of educate, and then kind of help the market to see that it's almost irresponsible not to be doing and using the latest technology and techniques. And so more recently, now that the world's and LLMs are eating up the world, we've kind of much more on the practical aspect of, just operationalizing these tools. So that's sort of what we're grappling with at the moment. It's actually a lot of the traditional technology barriers that have to be overcome, but AI does have its own special flavor of like, how do you actually get a clinic in rural South Africa to kind of use it. And we've got like paper-based scorecards, for example, that is based on AI and kind of able to work in those very difficult environments. And so kind of making sure our techniques are fit for purpose and fit for the environment, that's sort of what we focused on right now.
That's fantastic. And Safi?
Yeah, I think at the earliest days, the barriers are finding the right off-the-shelf technology to use, right? That's fit for purpose. And I really think, that should be the first step most people take, especially if you have less data. Try and prototype as quickly as possible to see if this is even an AI problem. At a sort of mid stage, it's how do you actually deploy this as part of your tech stack, right? Like, how are you going to do this? We work in low resource settings with limited funding, so like it has to be efficient, it has to be solving the problem, and it can't be super expensive. And then there's a sort of next magnitude question of that now when we have sort of millions of users and thinking about like how many GPUs you're using and things like that, that becomes expensive. So I think thinking about your infrastructure at a midpoint is really important because AI, it sounds great, it's silver bullet wise, but it is incredibly expensive at scale. Those 20 cents per API calls add up a lot. So figuring that out, I think is really important. And maybe the last thing I'll say is building a team that's fit for purpose at each of those stages is really important. You don't have to hire an ML engineer day one. We've just done it, 3 years into using AI at this point.
So, Safi, I'm glad you mentioned that because I want to return to one of the points Rebecca made around whether you build an in-house team or whether you hire an expert, or maybe you partner with someone else. And I would love for each of you to talk about how you've built the capabilities at your organization, maybe again, like starting out and then where you are now. And maybe we could go in reverse order, Safi, since you mentioned it specifically.
Yeah, so we are our team's entirely Kenyan. The tech team is entirely Kenyan. I was super proud of it, but I think we've had a lot of help along the way, right? So a lot of really good partnerships, deep partnerships with Microsoft Research, Google Health now, so many people along the way that have helped shepherd that team. I think it's quite difficult to find talent, so I think we've been quite lucky. I don't begrudge anyone, hiring externally to find that team. But because we work with language, because we're dealing with local contextual problems, it really helps to have a team that understands those issues as they're building tools to solve those problems. So for our particular use case, that's been the best path.
Right. Lucian, what does your team look like?
Just to echo again, Sathi, we've done most everything in-house. So we actually do believe on our core competencies, at least, the data science, the program analytics, kind of the field folks who go and operationalize these tools, those are all sort of in-house that we've had to build over time. But yes, it is challenging. And some of the things that came to mind was, be a great place to work because talent is scarce and expensive. Good folks are really hard to hire. And in South Africa, and I think a lot of Africa, the very best go to fintech. So as soon as you've got a nice thick resume on AI, fintech's grabbing you. So we're competing with these very, very lucrative alternatives. And what we've often said is that folks come for the mission and they stay for the culture. So getting that team and kind of resonating with those individuals is really, I guess, how we've managed to build and attract the talent that we've managed to do.
Thank you. And Yasmin?
We in Kenya, we have, and it's a very lean team. We have the team in-house, and in Tanzania, we have partnered with Afya Intelligence, which is a startup Tanzanian startup working in this space. But I sort of want to, I agree exactly with what Lucian said. It's very hard to, even our young team, we went to our first workshop, and it's the ministry workshop. You have about 20 different partners, and the minute the partners realized what our lovely AI engineer could do, he had like 3 or 4 job offers, and fortunately he stayed with us. But it is that thing. I think what really helps us is having local teams, because I think, as Sathi was saying, we're not working with large language models, but you do really need to understand the culture around data use and the sensitivities around how to access data, and it's really helpful to have someone on site because of the imperfections with the data as well. We've not been doing it so long. We're 1.5, 2 years in, so I don't know that we've progressed. We've got the same team we had when we started. Afia Intelligence has been great because I think they not only understand the data, but they also a little bit understand supply chains. And that's been really helpful as well, because I think it's not just about the data. We need the technical expertise as well.
Thank you. I'm going to turn to Rebecca in a minute, but before, I want to do a rapid fire question for each of you. How big is your team that works on this? So Yasmin, we'll go back. Like, how many people do you have? And I appreciated that you also brought up the very real challenges too of, keeping people once you find these great people.
1 person. He's awesome. He's young, full time, and then we have about, in Kenya, 4 or 5 people who also work with him. And then in Tanzania, we have about 3 people part-time, and then Afya Intelligence, I think, had 2 people, but not full-time. I think they would be. So, but I think our pace was set by the government, so it wasn't 100% full-time every day, except for George in our Kenya office.
Okay, great. Thanks. Lucian, how many people do you have, let's say, working on like
Yep.
a medium project for you?
We're about 13 total at the moment, and the complement is sort of a third data science, a third program analyst, which is kind of like this epidemiological skill set, and then a third like project management and executives. That's sort of how we run at the moment.
Great.
Yeah.
Thank you, Sathi. What does your
Our
team look like number-wise?
Tech team's 8. Of that, there's 3 ML people, including 1 intern. But when we started any AI stuff, it was just 1 person for the longest time, and then maybe 2. So we were able to do quite a bit with that. It's once you start getting to production and infrastructure stuff that you really need to beef up.
Okay. I feel like there's a lot we could learn from all of you. I'm gonna maybe just turn to Rebecca if there's any, like, what you're seeing in terms of in-house versus hiring outside help as you're getting started with your portfolio at the foundation.
Yeah, do you mean at our foundation or do you mean at our partner organizations?
I mean, sorry, at your partner organizations. Thank you. So yes.
Well, I will also name, because I think it is relevant to the conversation, that at the foundation, we've been very intentional about bringing technical expertise in-house. And we actually have a team that focuses on developing AI-enabled products and solutions tied to our strategic pillars. And we're doing some work right now to also, how do we position that team to partner even further with some of our partner institutions? And so from a, just to name from a philanthropy perspective, I do actually think there's value in having those technologists sit in-house and be able to both support on some of the strategic grant making that we do, but to also be part of that kind of product development ecosystem. And so that's something that's, I'll just name, is something that we do in-house. With our partners, like I say, I think this is a bit of a mix, and it's something that we're very mindful of when we're entering into partnerships. A lot of what we look out for, right, is what's and again, as I shared earlier, we really do try to practice that trust-based philanthropy. And so when we're asking these set of questions, it's not a, you need to have this team in place in order to receive funding. It's really coming from a, like, what are the resources you have to get this done, right? And so when partners come to us and they say, whether it was in supply, right, saying, we are going to partner with Afya Intelligence, and this is precisely how we're going to do it, and here's the team that is capacitated in-house to be able to do that, or whether it's Jacaranda Health that says, actually, we're building out that team internally. Like both of those fit our portfolio construction, right? Because those are institutions that have said, we know our work, we know our teams, we know what we need to get the job done. And it's our role as a funder to resource them accordingly to let them to do that work. So it very much runs the gamut. I think one of the things that I'll name is we still ask those questions because there are so many folks who say, okay, we have like a digital strategy, come and fund us or come help us, right? And so we really do get into or we have an AI strategy, right? Like, and then are seeking funding to implement that. And so the sets of questions are, how are you prepared to do that? Like, have you thought through those partnerships? Have you thought through that technical capacity? If you have an existing engineering team that hasn't engaged as much in sort of AI engineering or research, like where and how are you upskilling them, right? And so those are the sets of questions we ask that are signals. Are you thinking about this strategically and over the long run? But as I think we've seen on the call, there is no right answer, I think, on this one.
Great. Well, thank you. I know we could all keep talking. I do want to be mindful that we're going to wrap up in about 12 minutes, and I want to open it up to Q&A from everyone. And we've had some great questions coming in. And if we don't get to all of them, that's why we're asking about who's asking so that we can follow up. But I do want to turn us over. We have a special guest who's going to kick us off with the audience Q&A. And this is Professor Stathis Ganatas. He's an assistant professor in epidemiology, biostatistics, and computational precision health at UCSF. So welcome.
Thank you. Thanks a lot. And I have to say, all of the talks we heard today really resonated with me. And I'm very excited. Again, there's so much we could talk about. If I were to begin with a question to all the panelists, we know that going from defining your question and your implementation goals all the way to the actual deployment, there's many steps, there's many associated challenges. And I certainly work with very many different groups. They all have different expertise, different strengths. And a lot of my work is developing tools, so machine learning algorithms and software, to make all of these advanced technology as accessible to everyone. And so open science and team science is important, I think, to make the most of AI/ML in an efficient and safe and fair way. So we already talked a little bit about different teams, and one question I was going to address to everyone is there a particular part in your whole data pipeline where you would most need or appreciate external help and or collaboration of any form?
I'll just call people out. Safi.
Yeah, I think we're doing a lot of work on different languages right now, like expanding to Pan-African languages, and that's hard. You need to expand data sets. You need experts in terms of handling multilingual models. So I think that's something that we're grappling with right now. So putting it out there if anyone's interested in working on that, would love to chat.
Thank you.
Lucian, do you want to go ahead, or do you have any comments?
Yep, sure. Mine's a lot simpler. I think, FHIR, came up earlier, which is a standard for integration. And I think that just the integration part in of itself, I used to work for a big investment bank, and they kind of spent millions of dollars on getting all the bits of software and pieces talking together and creating a enterprise service bus. And oh my gosh, we don't have any of that in the sector, really. And getting all the bits to talk to one another and kind of create this unified view of the patient. I'll take some help on that. Thank you very much.
I would build on what Lucian just said as well. It's both ecosystems are pretty fragmented in terms of actually even data, the data that's collected. And then what we're trying to do right now is try and think through. So if we're trying to use AI to solve sort of pieces of the supply chain problem, how can those tools be fit for users, because I think what we've learned is the back end of the tools we've developed are, and they're open source. They're very similar, same approach methodology, but the user interface has got to be customized to that user and that use case for them to keep using it and adopting it. So how do you scale that model? Because it's not, it really is context specific. The back end and sort of, some of the back end depends on the data and the front end depends on the user. How do you put these together to solve different parts of the supply chain so people can use them individually or together? But also, how do you scale that model across different countries and geographies? So I think that's what we're struggling with.
Excellent. Thank you. Makes sense. Thank you so much.
And thank you for the question. I'm going to turn to a question from Daniel Musser from PSI. Where do you see synergies between FHIR, and sorry, this is for, I should say, Lucian and Rebecca. Where do you see the synergies between FHIR and digitization of client records through AI that was just described? So described earlier, is this maybe an opportunity for organizations to leverage standards with the MOH to improve AI for management and analytics of client data and make processes more efficient? So I know that was a bit of a mouthful.
Lucian, do you want to go first and then I'll build on
the question, yeah, sure. I mean, I think the simple answer is yes. Like, absolutely, like we should be leveraging these standards. I think it's easier said than done. I mean, it's not trivial to kind of even be FHIR compliant. And I think a lot of folks are struggling with it. And then even if they are, that again is not a silver bullet. There's still other challenges getting these different systems to talk to one another. Connectivity just being a very simple one. So I think anything we can do to kind of support and make sure that happens, I think makes sense.
Yeah, I mean, spot on. I'll name, I think, one of the things that I think will be very interesting, and I agree. So adoption of standards, I think, it's critically important both for how do we change the way in which care is delivered today, but also kind of set the stage for more inclusive and representative AI, right? So being able to share data, being able to collect it in a standardized format is, I think, there's a sort of hypothesis in there around connecting that to sort of more advanced analytics. But agree that it is a hard thing to adopt. I think one of the interesting questions, and this gets back to use cases in the space that are maybe a little bit more behind the scenes, are there opportunities, for example, with these large language models to actually support folks in becoming FHIR compliant that are easier? And so we have a number of partners that are starting to do some experimentation around this with how do you actually, can you create connectors that would enable you to become FHIR compliant? Is there things that we can do that are easier? And so I think those are interesting sets of questions to explore. I think one of the other pieces you mentioned, ministries of health, I'll name something that I think has come up for us again and again in conversation, particularly around like integrated primary healthcare, is connecting private and public data. And obviously an adoption of standard is not going to do that alone, right? Like there's a number, and harks back to some of what we were saying before, right? Around partnership, around data governance, around data sharing agreements, around building trust. There's a lot there, but we have a number of partners that are starting to explore adoption of FHIR and to sort of see here's the art of what is possible from a data and digital perspective that could actually let you have the continuity of care that so many of the partners on this call and so many of the folks in this space really care about. And so it in some ways it's an art of the possible, right? It's creating a conversation, but it is definitely not the be all end all. And I think that's something we need to be mindful of.
Rebecca, I'm going to give you a last question, but if you could be very, very brief because we're actually at time. And I do want to say there's this amazing conversation happening in the chat with resources for everyone if you're interested. But Rebecca, the last question maybe for you is you reference like not all problems need an AI solution. How do people, how do they ask that and how do they recognize that? And I know that's a hard task in like 30 seconds, but I'd love you to do it.
I'm going to try to do it. I mean, in 30 seconds is tricky. I mean, it comes back to like, what is the problem that we're trying to solve, right? What is the problem that we're trying to solve? Do we have the data to solve it? Do we have the people to solve it? Do we have do we have both the technical knowledge? Do we have the partnerships that if we solve it, we are able to scale it? Like those are all sets of questions that we need to ask around this. But I do think it in order to, I'd love to be able to give a specific answer, but maybe that's the 30-second version. And if other folks have a quicker one, they
Well,
can.
what I think I'm hearing you say, and actually I was gonna like wrap up before I hand off to Sarah Anderson, our executive director of the Bay Area Global Health Alliance, is it really is around like understanding the problem first. And one of the themes coming out of this is, we talked about human-centered design, but Yasmin talked about the problem being defined by users and recognizing that to many users, especially if it's new, it's scary. And Yasmin, I really loved your example too of letting your government partners setting the pace of the engagement. And I think this user understanding, and all of you referenced users in some ways too. So for example, like being built for purpose. And Sathi, I heard you also mention, prototyping and getting feedback along the way. And these are all very user-centered approaches to leveraging technology properly. And as a biodesign faculty member, I love to hear that, I'll just say. I do want to mention Lucian. Lucian, I think you had the best quotes for our panel today. When the first one is, we should have renamed our panel to navigating data in global health. Your point around imperfect versus perfect data, there's no perfect data. I also loved a quote that you had at another time, like, this is a crazy time. And I think just recognizing that, with these changes in technology and all the excitement, it's also can be intimidating and scary for many of the groups and the people who are implementing it and leveraging the technology. And so I think I would love to end there. Just one last thing I think I heard from all of you is just keeping humans in the loop. And you will have great tools if you leverage great people and they're part of the process. So with that, I really want to thank all of our panelists and our special guest, Rebecca, as well as our fireside fire starter question asker, Professor Ganata. So thank you all. And I'll hand it over to Sarah Anderson of the Bay Area Global Health Alliance.
Great. Thank you so much, Krista, and for the summary and wonderful moderation, and to Rebecca and to all of our panelists, Yasmin, Lucienne, and Sathi, for sharing your learnings, as well as we all begin to navigate these issues with AI. If you know about the Alliance, you know that we're very intentional about creating a trusted environment for really candid conversations. So we're very grateful to all of you presenters for really being those honest learnings, because that's what's going to move the needle as we move forward to improve health outcomes. A big, big thank you to our lead sponsor, Pfizer, for supporting our 2024 series and encouraging us to surface opportunities for future investment. Thank you, Pfizer. We also want to thank all of you who joined us today and hope that you will join us again. On May 21st, we look forward to seeing those of you who are members for our annual meeting. We have a great lineup of speakers and panelists. For those of you interested mainly in AI and global health, please mark your calendars for Tuesday, June 23rd at 8:30 Pacific times. We'll turn our focus to AI and the tools to support frontline healthcare workers. So thank you all again. This has been marvelous, and we really wish you a wonderful rest of your day or evening, depending on where you've joined for us today. Thanks again.